I now want to turn it over to Dr. Jeanene Smith, who is the administrator at the Office for Oregon Health Policy and Research. That organization provides oversight and coordination for all elements of the Oregon Health Plan and state health trends, provides technical and policy support to the legislative and executive branch decision-making on health policy. Jeanene also is a practicing physician, has been so for 15 years in both private and community-based practice, so she brings her provider hat to her work in Oregon as well. And this is a new innovative model that Oregon has implemented just recently, so we're very appreciative to have Dr. Smith here to talk about Oregon's approach.
Thank you very much for inviting me. We're very used to rain in Oregon. In fact, we are in the midst of another deluge, and I also, it's a pleasure to be in Boston, which I understand by a flip of a coin, I would be from Boston, Oregon, instead of Portland, Oregon, but little known fact that we actually have a new restaurant in Oregon with a it's called the penny, and it's the penny that was flipped to decide what it was called. But anyway, on the side note. So Oregon is trying to do a lot of things all at once, and the main driver behind that is we really had a burning platform of just outstripping our state budget for health care, and as many of you all know what that ripples through with a balanced budget states have to hold down. It ripples through our education and our other public safety issues. We were a very heavily managed care state. We had about 85% of our Medicaid clients in managed care, but we had siloed managed care. We had physical health managed care, we had mental health managed care, and then there was another group that dealt with the teeth of the managed care, managing their dental needs. We also realized that as we merged into what we created was the Oregon Health Authority, where we tried to look at all purchased lives. We also had rising cost in state employee benefits, very traditional vendor relationships with those health plans, and as well as with those managed care plans with very little accountability or tied to payment. And just a few but great efforts going around the state in terms of patient-centered medical home pilots and other multi-payer efforts, but on a very small scale. So Oregon, as usual, of course, we do everything through public process, as we have since the days of the original Oregon Health Plan and the prioritized list, which still exists today and is our underpinning benefit design in Medicaid. But we really sat down and came up with our new vision, which is very similar to Don Berwick's in terms of better health, better care, and lower costs. And we have tried to frame all of our efforts around that. And our health policy board has set out an action plan. We actually had health reform bill that passed prior to the ACA that was shaped around this in 2009. So we first started with patient-centered home. We call it patient-centered primary care home. I could tell you tales of why that's named that, but that's how it landed in statute. But it's basically Oregon's medical home model. But we, through a public process, developed set standards, and we tried to really think about it as patient-centered or person-centered and their families. And so the committee worked through kind of what does access to care really mean? Be there when I need you, my family and I need you, all the way to coordinating and helping us navigate and help activate us and engage us in our health care. And so we set up a set of standards that are based upon this measure, so that with the idea that everybody wanted to pay this way, but rather than have 7 different plans all say this is a medical home and this is a medical home, could we all agree? We looked at NCQA standards, and at the time we did this, we did not think they were paying for outcomes, but we're paying for process. We think NCQA has moved further, but we're still not there yet, and if you qualify for an Oregon standard, you can get to use your NCQA status, but you have to do a few additional things. And we have sort of different levels of primary care homeness. We recognize, because we are a rural and frontier state, not unlike Colorado, that some of the more rural small practices really couldn't achieve this out of the gate. But then there were some practices who, thanks to some support from some of the various health plans, particularly our large managed Medicaid plan, Care Oregon, had really advanced quite a ways. So we recognize that and have a tiering system of a tier 1, 2, and 3. And then we recommend that the payments would be based on that tiering. And the policy board set some ambitious standards of wanting to have all of our Oregon Health Authority covered lives to be in a patient-centered home. We have about 4 million folks in Oregon. And so we wanted to start to spread that and have worked collaboratively across the various plans and payers across the covered lives that the state dollars touch, including some of our premium assistance programs, and we recently expanded to covering all kids through one form or another, either Medicaid or in the private market. And then the goal would be to spread that across, and as Oregon is going forward with a state health insurance exchange, what was created here, we anticipate trying to tie that into the qualified health plans going forward. We are also one of the sites of the 7 communities partnering with the Centers for Innovation around the CPCI initiative, and so we have 5 payers around that. They're using the patient-centered home standards as the basis, although having to align, of course, with the Medicare requirements. But then that wasn't good enough. We had to do a few more things. And so we had our new returning governor come back, Dr. John Kitzhaber, who came in after having previously been there and started the Oregon Health Plan several years ago, and set up a lot of discussion, public discussion, that led to 2 major pieces of legislation. Initially in 2011 was a healthcare transformation bill that basically put forth to the authority, come back and tell us how you're going to do this. And then in February, which is not that long ago, the legislature said, okay, we agree, go forward and do this. There was strong bipartisan support, and in some ways even stronger Republican support in some ways, because it was the only way that we could really close our budget gap. As many of you know, as the ARA enhanced match has declined and rising healthcare costs have really left a huge deficit in the Medicaid budgets. Again, being Oregon, we had a lot of public meetings, and having been at almost all of them and staffed them with my staff, 75 public meetings when we totaled it all up to put into our Medicaid waiver for this. We really wanted to build on the healthcare purchasing through the new Oregon Health Authority, and we think of this as just the first step in what we'd like to see going forward. We have about 600,000 lives in Medicaid right now. We anticipate that we probably will go forward with an expansion, and we didn't know how we would address the access to care, as we have aging primary care providers. So we really looked at that as we didn't transform the delivery system, we couldn't have probably gone forward with either the exchange or the Medicaid expansion, and we didn't want to end up with expanding and then having to retract. As you may remember, Oregon had the pleasure of having to cut, I'm joking, of about 80,000 lives off the health plan back in 2003. No fun being in a Doonesbury comic about that. And we have our lovely lottery right now, which allows people to get into the expansion plan, where we only are able to afford to cover about 60,000. So we really look at the expansion as a way to continue to get more coverage and fuel the delivery system. So the concept is what is called a coordinated care organization. We have set in statute some parameters on what that is. None of the previous managed care plans would qualify to be a coordinated care organization because they had prescribed governance. However, most all of the coordinated care organizations are a mix of some of the previously siloed managed physical health plans and mental health plans. There's a prescribed by statute that their governance would have a primary care provider and a mental health provider on their governance board. They would have community advisory panels, and one of those would also be on the governance of this entity. And there would be demonstrated that they have a working community advisory council that would inform the CCO on how to function, and not just be like, oh yeah, we go talk to the community advisory board, but they're really engaged in the care going forward, and partner with the CCO to develop a unified community health assessment and target efforts by the CCO in that manner. The goal is to build upon the patient-centered primary care home as the cornerstone or bedrock of these plans, and they do carry risk. So the idea is to integrate services and benefits across the different aspects of care. There's one global budget that grows at a fixed rate. There are common metrics. We're working through the details of those exactly with CMS and hope to have those finalized here this month. And local accountability for that health of their community and that budget. And a lot of flexibility. The governor uses the concept of an air conditioner, offers quite a bit of benefit for a congestive heart failure patient down in Southern Oregon, and they found that they were able to save thousands of dollars in hospital costs. So trying to have some flexibility and benefits. The global budget is as we said, move away from the isolated silos to this one budget that is flexible and adjustable to be used by the needs of that community. There's some detail here, and I won't go into it short of time, but there's a capitated component. There's some optional services. By statute, dental services will be moved in formally, but some areas have chosen to take on dental coverage most immediately, and as well as some substance abuse treatments. And then there will be incentive payments, and we've just working through a public process of what those metrics would be. That will allow you, and about 16 metrics would be used for incentive payments for these CCOs to gain some shared savings. Initially, the first year, they would only be required for reporting, but would start to have to demonstrate some improvement in these areas, and we're setting some benchmarks. We've sort of made a deal basically where we're held responsible for costs between the federal government and us, and then we're holding the CCOs accountable from us down, and then ideally the CCOs would work with the providers. So the governor went back and helped negotiate the waiver and made the deal that we would lower the cost curve in Oregon by 2 percentage points. We're starting off at 5.4% to 3.4%. So those rates to the CCO cannot exceed and will actually be starting to go down when we calculate that global budget. In exchange for that, there is an investment to the state to pay for some things that normally we were paying for totally in our own state dollars. And as long as we meet those benchmarks that the feds are setting up with us to achieve these types of savings, then we will be able to continue to receive those dollars. If we don't succeed, then the governor has told them, okay, then don't keep paying us. Nice deal. People call us up and ask how great we're doing, and they find out about that deal, and then they sort of don't want to talk further. So there's certain things that 2% test applies to. We're sorting through where we are as a starting point as we speak. There are certain populations that will be contributing to that. It's still voluntary for those who are eligible for both Medicare and Medicaid. By statute, our long-term care housing costs are not in there out of political reasons. However, we know that the acute care side of those folks that are in those long-term care facilities, and we have Oregon is fairly progressive in not having a lot in nursing homes, but a lot in assisted living. We want to see transformation in how the care is delivered. So we have some key levers we think that will influence this savings. Patient-centered primary care homes, of course, being key. The physical and mental health integration, improved care coordination, the administrative efficiencies of not having these siloed health plans that couldn't talk to each other before, and then the flexible benefits. So we kind of hit the ground running. We posted for who would like to be a CCO back in March, right after that last short-term legislative session approved it. We negotiated our waiver over a 4-month period and are just finalizing the details currently. There initially were 8 CCOs that started, contracts in place by August, and we now have 15 CCOs as of November. We also are moving our fee-for-service into the CCOs where appropriate, so that we anticipate having 90% of our Medicaid population actually pretty much by now are in CCOs, and we know that there's a CCO in every county of the state. The larger Portland area has a pretty unique structure of 2 CCOs, and one of those is a combination of about 4 health plans coming together to do this, including several of our commercial plans that had been in Medicaid. So we want to go further than this. I also sit on the Public Employees Benefit Board, and we were going to put out this actually still says we were going to do a RFP in 2004. We're going to postpone that to 2015 so we can really refine that RFP to ask for similar accountability. It doesn't mean that every state employee will be in a CCO, but can we hold similar accountability of Regents or Providence Health Plan similarly as we are holding the CCOs for accountability and incentives to stick to the triple aim. We want to sort of mirror the Center for Innovation on a federal level by having a transformation center that would help engage the CCOs so they can share best practices. We already have a learning collaborative amongst our patient-centered primary care homes. And our exchange is up and getting started, and we want to look across and we have a little bit of crosswalk on our quality metrics, but can we do more of an expectation on what is a qualified health plan? And as I said, we really had no other place to go. As always, when you start to do reform, people go, well, couldn't we just leave it the way it was? But we really couldn't, and we really needed to move forward. There were a lot of champions, and certainly the governor and several legislators were key to make this happen. And we've really worked closely with CMS to be able to get the permissions to go forward with this. There's a ton of information on health.oregon.gov, and I open to any questions.